Our podcast today is sponsored by Midas Healthcare Solutions. They are elevating technology to help prevent medication diversion. Key features include real-time visual proof of compliant medication disposal, powered by machine learning and AI to detect drug wasting behaviors. Seamless integration with your ADC, EMR, and diversion software for efficient reconciliation of waste transactions, including identifying outliers. Anytime witness technology, providing flexibility when a witness is required for unused controlled substance disposal. And Rx Intercept for customizable, random, or targeted sample collection with secure chain of custody. Welcome back, listeners, to Diversion Insight Podcast. Today, I am excited to have with me Marianne Sevcik. She is a nurse who spent years working for the Joint Commission, and she now provides consulting services to hospitals around regulatory compliance and accreditation. Marianne, welcome to the podcast.
Hi, Terry. Thanks for having me. It's good to be here.
Thank you for joining us. In spite of, she was on site and got in at 4 a.m. So she's a trooper that she didn't cancel, and she's going through with the podcast here.
Travel adventuring.
Yeah, travel adventures. Yes, the consultants' travel adventures. That'll be our next podcast.
Sounds good. I have some stories.
They probably would be a good episode. Before we dive into our main topic, give the listeners a little bit of your background, your experience as a nurse and with the Joint Commission, and what you do now.
Sure. Well, hi, everyone. I am Marianne Sevcik. My background is nursing, and I've been in healthcare for 35 years. I've been licensed in 5 states, so I've seen a lot of different kinds of healthcare delivery, everything from small community hospital to large academic centers. I did a lot of leadership prior to joining the dark side, which most people consider as a Joint Commission. I consider myself a recovering Joint Commission surveyor. I was, after many years in bedside nursing and leadership, I was with the Joint Commission full-time for 5 years, traveled this great nation, and conducted surveys. The last 4.5 years, almost 5 years, hard to believe, I've had my own consulting business. And so I help organizations prepare for the test I used to give. And it's my pleasure to every single week be exposed to leading practices and just helping organizations find solutions for problematic areas when it comes to regulation and accreditation.
Very cool. Yeah. I think after spending some time talking with you, I think we're kind of cut from the same cloth. And I've had people actually say to me, whatever you do, don't go be a surveyor because you're scary.
You know too much, Carrie. You know too much.
Yeah, exactly. All right. Well, today I want to talk about something that probably keeps a lot of pharmacists, directors of pharmacy, and compliance folks up at night, and that is Propofol. It's an interesting medication that sits in kind of a regulatory gray area. It's not a controlled substance, as you know, but it definitely has addictive and diversion potential, right? Yeah. So can you start by giving us the Joint Commission's perspective on Propofol and how hospitals should be thinking about it?
Yes. Well, I think it's important to know, first of all, you brought out the main topic, and that's that it's not actually scheduled at this time, although there have been attempts in 2010, I think was the most significant one. But the Joint Commission, really the regulations that the Joint Commission holds to are the CMS standards. So CMS has what they call conditions of participation. If you ever receive Medicaid, Medicare money, which all hospitals and clinics do, you have to comply with those conditions of participation. It's important to note that the Joint Commission, their first obligation is to make sure that organizations are complying with those conditions of participation. So in essence, you're getting 2 surveys. You're getting the CMS survey, and you're getting the above and beyond that are the Joint Commission standards. So you actually get 2 reports. So with that being said, CMS isn't overly descriptive on medications that are not scheduled. The Joint Commission, however, talks more about safe practices. So there are standards that are more vague, that you can place these kind of things in when the surveyor comes in to find a practice that doesn't look safe, that there's not a process. Those are the things that the Joint Commission surveyor are looking at. I think it's important to note history. I always like to follow the leadership trail.
Mhm.
So one of the things as we head into this conversation, Robert Campbell, who is a pharmacist, was a former surveyor, and he's now the director of Standard Interpretations Group, which is the hotline that any surveyor can call when they get into issues that they aren't able to resolve with an organization if they see a safety practice that they're questioning. And I can tell you that Dr. Robert Campbell will always support extra safe measures surrounding propofol. And I'm sure we'll get into it more during our discussion, but there are reasons for that, and they're not unwarranted. So in recent surveys and on mock surveys that I've been on, we see that those safety practices are still being scored by the Joint Commission. So they end up on your report, and you need a plan of corrections once those are on your report. So it's vague, but I can tell you that propofol is cited very frequently in terms of safe practices.
Okay. So practically speaking, because, we got to be practical, right? It's got to fit into real life.
Yeah.
Propofol is large bottles, can be, right? If you've got the 100 mLs, it doesn't fit in those secure cubbies and the automated dispensing machines. And so most hospitals put it in their ADM, but it's in their cabinets, right? Yeah. So you need a password, you need to go in, it's secured in there. But when you go in to get, ampicillin, well, maybe not ampicillin.
There it is.
Be in the refrigerator, Cipro, then there it is, right? So how do hospitals meet that obligation when it comes to security, even though technically it's not required? Have you seen any facilities do it well?
Great question, Terry. So again, I'll lead you back to the Joint Commission isn't specific. As your surveyor, if I was on your site today and I saw it secured and that there was a process surrounding it, good accountability, there were counts done by pharmacy when anesthesia gets in there, those would be considered safe practices at this point in time. So some of the safer practices that I've seen surrounding that are simply having it locked and yet having that accountability count, including that on a diversion type count. So even though you can open it and there it is, it's still secure and it's still only accessible by licensed professionals. So that would be considered compliant.
Okay. So as long as it's on a blind count, now if it was only accessed once in the last 48 hours and the count is off, we'd have to open up the investigation to everybody who went into that cabinet in the last 48 hours, but at least we'd know that something was missing.
Correct. My concern, one of the things that I've found frequently is I'll walk into very notorious, every surveyor knows they're notorious, the anesthesia workroom.
Yeah, I knew that's where you were going.
Yeah, many things. We refer to it as it's like a candy store. A lot of times you walk into those workrooms and there's no accountability. I see propofol up on shelves. Yeah. That is non-compliant because there's no accountability for it.
Gotcha.
So if it's locked, it needs to be locked, even in those rooms where there is an accountability from a pharmacy perspective on how many vials are we storing here and how are we reconciling when they take those vials and they put them into their automatic dispensing machines. Just that there is accountability there. That's probably one of the most frequent finds that I have in regard to diversion. That and of course improper wasting.
Okay. So it's really kind of two different levels. I mean, from Joint Commission and security, as long as it is locked and there's a count.
Yes.
From a diversion perspective, like I said, if it's been 48 hours and I've got to look at all the people that have accessed that cabinet, that's not a great, but so it's kind of that two levels.
Yes.
So if someplace was storing it locked, the best that they can, right, open but yet locked, and there was a diversion involving propofol, would the defense, as far as the Joint Commission and what you've seen, be, well, I mean, we had it locked and we're not required to treat it like a controlled substance. So would that kind of defense work as far as the Joint Commission was concerned?
That's a great question. So again, the Joint Commission in and of itself is not that prescriptive. You have to follow your own internal policies. In many things, CMS or conditions of participation or the Joint Commission standards and regulation go back to following your own policy. So
Yeah.
at that point, if they came across some type of diversion activity regarding propofol, they would look into your policy to see what kind of safe practices you have. Things happen. If you are following your own policy and you are acting according to the safety measures within your own policy, the Joint Commission accepts that as compliance.
Okay. And I guess a broader question for me is, if a hospital has a diversion event or suspects diversion, whether it's propofol or a controlled substance, does the Joint Commission have expectations for the hospital's response and investigation process, or do they kind of stay out of that?
It's very rare for us to do a deep dive into that or some kind of a sentinel event, unless we come across we uncover in our tracer activity, which means, we're looking for compliance, but all of a sudden we stumble upon something that we really weren't looking for, like a huge issue with diversion. We find, like in this case, propofol everywhere in an anesthesia workroom, and there's no accountability. The organization wasn't following their policy. We just keep pulling that thread to find a solid practice that's at least showing that the organization has been responsible and accountable. And in the event that we get to the end of that rainbow, so to speak, and we see that indeed there was no good policy in place, there was no risk assessment done. I'll come back to that later. A risk assessment is a great thing to do surrounding an issue like propofol, because you're showing that you've weighed your pros and cons on this gray issue, and that you're mitigating your risk. That's what a solid risk assessment does. I would recommend that to anyone who is trying to come up with safe practices surrounding propofol or any gray area like this. If you conduct a solid risk assessment and you present that to your Joint Commission surveyor, many times they'll go through that with you and say, okay, you have your eyes on the ball. Things do happen. You're correcting your issues as you find them. So again, the Joint Commission isn't overly prescriptive.
Okay. The Joint Commission, is that one of the agencies that a hospital should notify if there is a diversion, or only if there's patient safety involved?
No, there's no requirement for notification other than sentinel event, and you do not have to notify the Joint Commission. You do have to notify an organization outside of yours, of your choice. There are many organizations that are set up that way for sentinel events. We call those never events. And I know this isn't my area of expertise, but I'm certain that in your area, Terry, there are many ways in which you must report these types of activities as well to state and federal reporting agencies. But the Joint Commission itself does not require you to report those. And technically, the Joint Commission doesn't have any right to come right in and say, show us your last diversion. That's not what we're looking for. We're looking for safe practices and the organization's ability and accountability to follow those safe practices.
Okay, so related, but not specific to diversion, but definitely overlap there. Let's talk about the risk assessments. We hear that a lot, do a risk assessment. For those that have never done one, maybe kind of new to the field or don't have their risk department that is, engaged or being proactive, what does that mean? Let's talk about it maybe for like the pharmacy director, right? Do a risk assessment. What does that mean? How do they go about that? How do they just keep it in a file folder somewhere and they can whip it out if it comes up? Is it a proactive thing to hand it over? Like, I know you're going to find this, so let me give you my risk assessment. I know the answer for that one, but let's talk about that.
Sure, absolutely. So I think we've seen several rewrites, and we'll talk about that probably on a later podcast, but the Joint Commission just completely rewrote all of their standards, which was a surprise to most everyone. They go effective January of 26. That was announced on July 4th of this year. So it's brand new, hot off the press. I think what we're finding in these rewrites are that they are expecting organizations to be proactive in terms of calling out your risk and then having a solid plan to mitigate risk. We understand that we work in an organization that's full of risk. It's what we do. So we want to call that out and recognize that risk. That's what a risk assessment does. Here are our risks in whatever given area that you're talking about. And here is how we're going to mitigate that risk. I think one of the things that the Joint Commission is looking for as they assess a risk assessment is that it's a well-used document. It's one that grows and changes. It has some names for who's responsible for pieces and parts of the risk assessment, if there are any assigned duties, that you change and grow with it. If something isn't working on that risk assessment or you find a new area of risk, you enter a new mitigation. They want to see that that is a document that is well used, not just some formality. And I find them actually very helpful because when you pointedly look at any issue that seems gray, whether it's use of propofol and diversion or increased surgical site infection, you need to get to the bottom of your problem in your specific area and call out those risks and then determine how best in your organization that you are going to try to mitigate those risks and make those things specific. It's good for any organization or department to go through those. And yes, the Joint Commission pays attention. If you were to bring me a well created risk assessment, I would shake your hand and say, well done. Let's talk about how you're mitigating your risks and how you're doing on that. So again, keeping data once you've developed that risk assessment. In terms of how do you get a hold, how do you begin as a newbie, as somebody who's never done a risk assessment? Start with your quality department. They have templates for all kinds of risk assessments. And Terry, I'm happy to make available to your listeners templates for risk assessments to get them started. But of course, making them meaningful to you and your organization is
right.
Goal.
Okay. So you would expect to see a living document. We tried this in 2021 and this was the results, and then in 2022 we did. Okay, it's not just a one pager.
Yes.
This and what we've done. Okay, so yes. A lot like MERP. I don't know if you've done anything with MERP. Yeah. Okay. All right. Yeah. All right. Okay, that sounds good.
Yeah.
All right. So now you mentioned the DEA was looking at making propofol a controlled substance. Do you think that if they did that, that would actually help hospitals or would create more problems than it solves?
That's a sticky question. So, yeah, it's going to be painful.
You're forced to do something, but it's going to be a problem.
It's painful. We all know, especially in your world, Terry, that when medication is scheduled, it creates all kinds of documentation, work flow, and different storage, wasting, and again, reporting and all those kind of things. So at the end of the day, yes, it would be as painful as anything else in terms of a new regulation. So I think what we have to ask ourselves in healthcare is, do our pros outweigh our cons? And I think that's the larger national discussion on this. In 2010, they decided no. Interestingly, it was prior to that, it was the death of a very high profile, Michael Jackson. Propofol was implicated in his death the year before. And I don't know if it was coincidence, but that brought national attention to the issue. And in my thoughts, I think it's a matter of time before it does become scheduled because abuse and diversion are on the rise with this And some of the DEA research that I've read has it lower, but it states in terms of use and misuse and diversion, but that's because FDA agents don't look for it because it's not scheduled at this point. So they're not seeing, I think if they would open their eyes, they would see a lot more in terms of like the Association for Nurse Anesthetists. They say upwards to 41% of anesthesia providers, 41%, this is the drug of choice for diversion and use.
Yeah.
41%.
Well,
that's
yeah,
ugly.
I mean, yeah, and it's not like you said, it's not being monitored. So you're constantly needing to find your way around whatever systems are in place. And this is a good one. Yeah, it's interesting because it is on the rise, but yet when we talk to anesthesia chiefs and anesthesia departments and we go on site to facilities, they are like, oh, who would use that? No, that's not a problem. I mean, it hasn't caught up yet with people in the facilities thinking it's a problem. No one would deny that fentanyl or midazolam, in the OR could be a problem. Right. But they don't, they're like, no, why is that a problem? So it's kind of interesting, I think.
Yeah, it is. I get a lot of pushback from anesthesia providers as I travel. First of all, when I was the Joint Commission surveyor, a lot of pushback regarding Propofol. I think the biggest area of opportunity that I see are waste in ORs, because inevitably you see the anesthesia machine sitting there and then a wide bore waste container. Anesthesia is busy, they're going between cases and they just rake everything off into that wide bore waste container. And it's very easy to spot. Of course, they call it milk of amnesia for a reason. It looks like milk. It's easy to spot whether it's in a syringe or not. And when I'm traveling around with the quality team and I say, look at all that Propofol in that large waste container, I can get access to it right this second. They said, who in their right mind would do that? Well, someone who is diverting and using isn't necessarily in that right space in their mind, and they know exactly where to get it. So again, that is an issue of noncompliance, those wide bore waste containers. Anywhere there's an anesthesia machine, I look in the wide bore waste container.
Yeah, 100%. Yeah, I worked at a smaller independent hospital when I was there. I was a medication safety officer at the time, and they came to me, the nurses did, and said, this is bad. All of this Propofol in these big containers. And it was a nurse-driven initiative to pull that out of every Propofol bottle, the waste, and, dispose of it in a different location and not just leave it in the bottles, which I was really impressed that, to convince nurses and anesthesia providers to do it, it would take a lot of convincing, but they drove the initiative.
Cheers to the nursing staff.
Yeah.
Cheers to the nursing staff on that one. I think this is where, it really does take a multidisciplinary effort, and because of the different perspectives that everyone has regarding some of these issues. One of the more interesting observations that I had of noncompliance surrounding scheduled medication, you mentioned fentanyl, was I was at an OB unit, and large OB unit, thousands of deliveries a year, very busy. And the nurses were very excited that they had gotten competency to be able to go ahead and pull the anesthesia catheter. And, that was creating a much smoother transition for them. They didn't have to call anesthesia to do that. And that brought me to ask the question, so are you then taking the fentanyl, which the epidural is, running with fentanyl, are you taking those cartridges out of this pull, out of your automated medication dispensing, they said, oh yes, we've all had competencies for that. We know how to use I said, we know how to take it out. We have the key, we can get it. And again, you try to keep the straight face. And I just said, well, where are we putting those cartridges of fentanyl? How are we doing that? How are we wasting those? The nurse leader said, oh, we got this. Let me show you. She took me to their medication room, which was locked. And they had gone to Walmart. It looked like they had a large kitchen garbage container.
Oh, gosh.
Those cartridges were being full to the top of fentanyl. And again, you try to keep the straight face. And I said, well, how are we accountable for these? Oh, we're doing our count in the automated medication. We're showing that we wasted it, but here's where we wasted it.
Mm-hmm.
We even have a witness that we put it in this big Walmart garbage can. So again, sometimes I think in the hospital setting, we just try to solve problems in a problem-solving way, and we
Mm-hmm.
think a solution might work. We don't include all the stakeholders, such as our medication safety officer. We don't include all. We just think we have a great idea, would work at the
Mm-hmm.
house,
Yeah.
and they don't get buy-in. They don't get those expert opinions as they're creating a process. This is where we find noncompliance, is when someone has a great idea, but they haven't included all the stakeholders in the process to make sure that it's actually a safe idea. I think we're finding the same thing true with Propofol, as you just mentioned. The nursing staff were like, hey, time out. This is a problem.
Right.
So I think it takes all the voices and calling it out
Yeah.
and looking for something safer as a team.
Right. Yeah. And you're right. I think people learn that over the course of their career if they don't have someone to kind of mentor them and to put up the hand and say, wait, you do have to get all of the disciplines involved, even for something you think is very, very minor and
Yeah.
would not like, why do we have to bring this to nursing or med staff or, this is a pharmacy thing. Why would we have to engage? But you start to talk about it and you realize, oh, but wait a minute, that affects us here and, here and downstream. And those are lessons that some of us have had to learn the hard way because we have been a little short-sighted. But when you do it a couple of times, then you don't do it anymore. Because you realize that. Very true.
I think outpatient surgery centers are also, in my experience, you can find many different types of practices there surrounding medication. I've seen, in my experience working with regulation and compliance, technicians who have access to Propofol. Of course, that's non-compliant. They just have it in a locked box in their procedural room. And, of course, the provider is the one actually administering that, but the tech gets it all set up and they have access to that. And there may or may not be a log there. So again, I think that when we set up our processes, we need to make sure that we are involving all the stakeholders in those things, like bringing pharmacy on and saying, there's that one standard in the Joint Commission that says pharmacy basically has oversight of all medication throughout the footprint of the organization. So whether that's sample medications, whether that's outpatient procedural areas, whether that's inpatient and in your ORs as well. And I think that's the standard most frequently cited in an outpatient setting, is that pharmacy didn't have oversight here. Because if a pharmacist had been here, they would have known that they can't just put Propofol in a locked box on a wall and allow a technician, to access it.
Yeah. Let's talk about that, because I've seen places where an anesthesia tech has the backup supply and they take care of non-controls in the anesthesia cart. They refill it. So it might be in a locked cabinet within the, we talked about the workroom with all of the other non-controls. So pharmacy, they get it from pharmacy in some way, and then anesthesia techs are now responsible for putting it in the carts. But you throw Propofol in there with that. Does the Joint Commission have a stance on that? If the Propofol is locked in the anesthesia workroom, but it's the techs that are putting it in the automated dispensing machine?
So anesthesia techs are a different type of tech. There is oversight by anesthesia, and there is an accountability there. Whenever I see an anesthesia tech involved, I tend to assume the best, and that is that there's direct oversight by, anesthesia providers, and that there's that accountability from pharmacy. They are counting what they are adding to or taking from any type of locked area. What I was referring to in terms of outpatient settings, sometimes you'll have radiology techs that have access to that, or you'll find an ultrasound technician who's doing some kind of an ultrasound. I've seen all kinds of things. So when I refer to techs, I'm talking about radiology technicians.
Okay.
They label them as technicians, but
Sure.
what are their qualifications? With a pharmacy tech, you look at that job description and you see, what are you requiring of that pharmacy tech? What does their continuing education and competencies look like? What kind of oversight do they have? Generally speaking, that's a fairly tight process.
Sure. Okay, that makes sense.
Mhm.
Any thoughts on anesthesia gases?
Yes, that's yes. Same difference. It's
Okay.
just you walk into the anesthesia workroom and voila, there it is. Anesthesia gases are everywhere. Those also need to be locked. It is an issue of noncompliance, just as propofol would be. Needs to
Yeah.
be.
And what is the stance on there are some hospitals where pharmacy does not order the gases. That is 100%
Yeah.
anesthesia. However they take care of it, they take care of it. Pharmacy doesn't touch it. What are the thoughts on that?
I'm going to sound like a broken record. Risk assessment.
Okay.
Um,
Okay.
you have all kinds of disciplines that go into healthcare, right? And highly educated, licensed, and they we can find pockets of those professions that just kind of do their own thing. I find surgeons sometimes bringing in their own implants when
Right.
the organization isn't aware of that. We
Yep.
have to. It needs to go through the organization's process. So a safer option would be for that to go through pharmacy. But if it's not, how are we monitoring that situation?
Okay.
Uh, again, sadly, you just gave me a new question to ask. How are we monitoring this process, right? Um,
Yeah.
because again, your background, you know that maybe anesthesia providers do that. I'll be honest, that was something I was not aware of. I know that surgeons can bring in their own implants and actually their own personnel sometimes into surgery, and we
Mhm.
have to make sure that those are cleared per the organization's internal
Right.
process. But
Right.
again, risk assessment. Uh,
Yeah.
you know, what is your policy state? Can you do that? What is your mitigation surrounding possible issues with that process? And how are you mitigating your risk?
Okay. So it's not wrong that anesthesia does it. Pharmacy just needs to be aware and then make sure there's no policies contradicting it and review it. I mean,
Yeah.
is that appropriate and should it change? If not, the risk assessment is on file.
Mhm.
Yeah,
The
and
finding,
it's go ahead.
sorry, the finding goes back to pharmacy though. It's going to be pharmacy's fault according to the observation. It's going that
Okay.
finding would more likely be that pharmacy
Anesthesia
didn't have
gases.
oversight. Didn't have
Okay.
oversight. And
Okay.
then the second one, it wasn't secure. So number one, it wasn't secure. Number two, pharmacy did not have any oversight of this.
Got it. Okay.
Oversight doesn't mean complete control, but you have to have oversight.
Yeah. Yeah.
Many physicians' offices have medications too that they're ordering, but pharmacy has oversight of that if it's within an organization and that physician's office is owned by the organization.
Okay, yeah. And, a shout out to the listeners. We're talking about in the OR, these things going on, bringing in their own supplies and stuff, which doesn't fall under pharmacy. Although I have worked somewhere before where an anesthesiologist was bringing in their own kit, bundled kit of stuff.
Yeah. Yeah.
And then there were meds in the kit, and the meds that weren't used in the procedure ended up in supply, hospital
Oh,
supply.
yeah.
So it's like, where did this ampule of lidocaine, whatever, come from? We don't have this. And that's what, eventually led into what? You can't do that.
Yeah.
So there's lots of things that may be happening in the
Yeah.
OR that we're not aware of. And so it's
Mhm.
to know to ask the questions. Don't just assume that everyone's, doing what they're
Absolutely.
supposed to do. Yeah, you just don't think about these things until it happens.
Yeah.
Yeah.
But I think if you have a good process and policy, and again, if you have an effective if you have effective leadership in pharmacy,
Yes.
they do chase that rabbit down the hole, figure out what
Yeah.
was going on there, and then take control. Again, uh, things happen. It's
Mhm.
just that when they do, what are we doing about them?
Right.
And I think that's the better question to ask,
Okay.
especially even as a surveyor. Okay, so that happened. What did you do about it? Those are things to even brag about. Look, this happened to us. The data was showing this issue. Here's what we put in place to mitigate our risk, and now our data looks really good here. So, learning from your own unique issues that pop up, because you're right, every organization has its own unique problematic issues.
Well, Marianne, you sound like you were a reasonable surveyor.
I'd like to think so.
Yeah.
Yeah. That's a funny thing you should say, because I was in the Joint Commission. There are some that are less than reasonable at times. I think overall, your Joint Commission surveyor is trying to give an accurate report of what they see. They are boots on the ground. They are just trying to objectively assess. But in the event that you have issues with your Joint Commission surveyor, you just don't see that you're seeing eye to eye, you can ask that to be elevated with a call to their experts at the Joint Commission, and you can have a collaborative call. I think sometimes we get nervous about that because we think, oh my goodness, I don't want to elevate this any worse. We'll just take our hit. If you feel like you are in compliance, or that you really don't understand what the surveyor is talking about, or you feel like they're really not qualified to have the discussion, you can tell that they don't understand what's going on. They can't be all-knowing. I recommend asking to have a call with their standard interpretations group in Chicago, and that's available to you if you're a Joint Commission customer. You can go to your team leader with the Joint Commission team and say, look, we'd like to have a special issue resolution. We would like to sit down as a group. We want to understand this. Of course, we want to comply. Of course, we want to be safe. But we would like to have a broader discussion with your experts at the table and our group together as well. So again, those things are available. I don't think a lot of people are aware of that. And then some are afraid to use it, which you shouldn't be. They're actually very collaborative calls. And many times an organization will show compliance and the surveyor learns something new. So
I think maybe some might be afraid, maybe the call would be collaborative, but the surveyor would not appreciate that it's being escalated. And if you're in day 2 of day 5 and you've got 3 more days, I mean, any suggestions on how to handle that?
Yeah, I call it survey psychology. Multiple things. I think, again, most Joint Commission surveyors are reasonable. They go through a lot of education and, at the end of the day, if you're with the Joint Commission, you are their client. They do have to do customer service. They do try to play well in the sandbox, so to speak. But if you find you're in that position where you have someone that's having a bad day, being inappropriate, doesn't seem to see eye to eye, is argumentative, seems to be monologuing on an opinion, and you're not quite sure if that's a fact, I would always say elevate that higher. You may find too, if we'll say in your world, pharmacy, your pharmacy leader may not be the person to talk with that person. Maybe there's a personality conflict. Maybe there's high conflict within both personalities. Just because we're leaders within an organization doesn't mean that we're great communicators either. Always make sure that you have someone that can communicate as best as possible with that Joint Commission surveyor and change it up if needed. But I would never hesitate to elevate that. You are allowed to also give an evaluation of these Joint Commission surveyors after they leave. The quality team does that, but as a Joint Commission surveyor, I read those evaluations. That does come back to you. Of course, names are redacted, but the feedback does come back, and it does go to the surveyor's field director, the one that manages them, and those things are discussed. So again, it may feel kind of crunchy in the moment, but it's always best, I think, to elevate those things as long as you're really certain that there is an issue with you are complying and they're just not seeing the light.
Okay, that makes sense.
You can educate them too. Look, I'm a pharmacist, that's your world. This is what we know. And our state laws are different from maybe the last state you were in. I think this is something to bring up too. Always be prepared to educate someone. Look at their bio. They come with a bio. What is their background? Would they have any information? Sometimes it's a pharmacist, so then it's going to feel more granular. But
Right.
look at their bio, see what their background is, and understand that they get off an airplane, they go to a hotel, they drive to an organization, they may be in 2 organizations a week, and it's all year long. Sometimes they don't even know where they're at. So orient them to your state if you have special rule, law, and regulation that might be different from another state as well.
Okay. All of that makes sense. Thank you for that.
Mhm.
Overall, in the hospitals that you've been working, as a inspector and then now assisting them with being prepared for it, do you feel that hospitals are getting better at mitigating and addressing diversion and controlled substance security, or do you think it's kind of business as usual based on what you've seen over the years?
Hmm. That's a great question. I think with any issue this broad, you're going to find pockets of excellence, and you're going to find areas of great weakness. And as a surveyor, I've seen both, pockets of great excellence. And to those, I always ask them, elevate your practice, share with others, teach, educate, become a thought leader. We need to get out these safe practices, these things that we're doing that we've thought outside the box. And yes, like on today's discussion, Propofol may not be scheduled, but it's an issue. So here's how we're taking the lead on it. I've seen organizations do that, and they put themselves on the map in a wonderful way. They share great leading thinking and thoughts, and they share great practices, and they show how practically they have overcome the hurdles so that you don't have to reinvent the wheel, and you can, follow after in as much as your organization would be amenable to their solution. But you can begin with a template there. I always say, if you have a good process, share it. But I've definitely seen those that are struggling. I think the most problematic things that I've seen are not from a pharmacy perspective, it's more from a provider perspective, that they simply stonewall and don't want to be inconvenienced, whether it's documentation or how it's stored or how quickly they can have access. So those are probably issues that I see not getting better. Those issues seem to be profound. And I think it's time to have a conversation at a broader level with providers and pharmacy and nursing sitting at the table and talking about the implications of the freedom the providers tend to want.
You made me think of something else. I was just getting ready to wrap it up here, but now there's another issue. You see that, and it's whether it's the director of pharmacy or whoever else it is that's trying to make the decision, they run up against those walls. And it's like, I know it's a risk and I've tried and I'm not the decision maker and I can't get the buy-in. Do you have a recommend? I mean, are they like, too bad, you're screwed if, something happens? It doesn't matter that you realize it and you just couldn't get somebody to go along with you. Should they put it in their risk assessment? Like, I tried and the chief wouldn't do it, or do you have any thoughts there?
Yeah, right. Okay, this is again that psychology within an organization. We all come up against those very strong personalities, very intelligent. I mean, in healthcare, we're smart people, and we have our own way of thinking, and that's what makes us brilliant in so many ways. And yet, we can be, lone rangers, and we need to get reined in when those Lone Ranger practices become problematic for the organization. In terms of running into those problematic, following it up the chain of command, so to speak, you can go as far as you can go. And I would definitely say, from your own risk perspective as a pharmacist, keep a paper trail. It's one thing for an organization to get a finding of noncompliance, and you can just say, well, we did everything that we could, and we know that we did. And the organization, hopefully, because it's on that report now, somebody will say, Oh, they've been trying to tell us this for the last 5 years, and we've been
Right.
stonewalling, and now here it is on a report as high and widespread or an immediate threat to life, but that uh, the leadership that was involved from a pharmacy perspective has kept a paper trail showing that they they did everything within their power to try to mitigate what was going on or to try to have those conversations. So I think from a personal risk perspective, to keep that paper trail, but also sometimes it's not a bad thing that that ends up being non-compliant on a report.
Yeah,
Sometimes that's what it takes to
exactly.
make it move. And then I would say after that report comes out, um, go with the momentum,
Yes.
rather than the "I told you so."
Yep.
Okay, now we can see together as an
Yeah.
organization, this is an issue. Let's put our heads together. Let's come up with
Yeah.
something that works.
Yeah. Like, oh my, look at the problem we have. Yeah.
What a
Yeah.
shocker.
Yeah. Oh, who would have known? Yeah, no, you're right. I guess it's too the facility will still get the finding, but if there's a potential license involvement
Yeah.
or, loss of job or even just to make yourself feel better, it's like I tried, like it was
Yes.
there. This is not on me.
Keep a paper
Um,
trail.
Keep a paper trail. Yeah.
Yeah.
Okay. That's usually what I tell people. So I'm glad I've been giving them the right the right instruction.
You give a lot of
Okay.
good instruction. That is a good one. Mhm.
All right. Well, Marianne, thank you so much for joining us and sharing your expertise on these issues. And to our listeners, thanks for tuning in. If you're dealing with propofol storage channel challenges or anything else, medication security wise, I hope this gave you some clarity or at least some practical things to think about to mitigate that risk. So I thank you all for listening and thank you, Marianne.
Thanks. It was a pleasure, Terry.
A special thanks to our sponsor, Midas Healthcare Solutions. If you are attending IHFDA September 29th and 30th, be sure to stop by their exhibit to discover their innovative technology. Midas offers solutions for med surg areas, procedural suites, and pharmacies. Visit www.midashs.com to schedule a demo and learn more about their technology.